Hello and welcome to this module of Respiratory Medicine where we will be talking about bronchiectasis. By the end of this module, you should be able to define what is bronchiectasis, outline the pathophysiology of bronchiectasis, recall the etiologies of bronchiectasis, establish a diagnosis of bronchiectasis, formulate a management plan, and finally summarize the complications of bronchiectasis. Let's get started. The term bronchiectasis originates from the Greek term bronchia, which means branches of the main bronchi, and ectasis, which means dilatation. Bronchiectasis is a condition of abnormal and permanent distortion of one or more of the conducting bronchi or airways. A quiet form of bronchiectasis occur in adults and older children and require an infectious insult, impairment of drainage, airway obstruction, and or a defect in host defense. The tissue is also damaged in part by the host response of neutrophilic proteases, inflammatory cytokines, nitric oxides, and oxygen radicals. This results in damage to the muscular and elastic components of the bronchial wall. The result is abnormal bronchial dilatation with bronchial wall destruction and transmural inflammation. Impaired clearance of secretions causes colonization and infection with pathogenic organisms, contributing to the purulent expectoration commonly observed in patients with bronchiectasis. The result is further bronchial damage and a vicious cycle of bronchial damage, bronchial dilatation, impaired clearance of secretions, recurrent infection, and more bronchial damage. There are a wide variety of causes, and they are as listed here. Post-infective, usually secondary to tuberculosis, measles, pertussis, and recurrent pneumonia. Cystic fibrosis. Bronchial obstruction secondary to lung carcinoma or foreign body. Immune deficiency such as selective IgA deficiency or hypogammaglobulinemia. Allergic bronchopulmonary aspergillosis or ABPA. Ciliary dyskinetic syndromes such as Cartagena syndrome and Young syndrome. Lastly, yellow nail syndrome. Let's look at one of the commonly discussed areas in bronchiectasis, primary ciliary dyskinesia. Primary ciliary dyskinesia is characterized by reduced ciliar motility throughout the body. This results in recurrent chest infections and bronchiectasis, but also can result in male infertility. When primary ciliary dyskinesia is associated with situs inversus, it is known as Cartagena syndrome. However, this only happens in 50% of primary ciliary dyskinesia. Most common organisms isolated from patients with bronchiectasis are Haemophilus influenza, which is the most common type, Pseudomonas aeruginosa, Klebsiella species, and Streptococcus pneumoniae. Clinical manifestations of bronchiectasis are as follows. Cough with daily mucopurulent sputum production, often lasting months to years. This is a classical picture of bronchiectasis. Blood-streaked sputum or hemoptysis from airway damage associated with acute infection. Dyspnea, pleuritic chest pain, wheezing, and fever. Findings on physical examination are non-specific and may include the following: crackles and scattered wheezing, digital clubbing in 2 to 3% of patients, more frequent in moderate to severe cases, cyanosis and plethora with polycythemia from chronic hypoxia, wasting and weight loss, physical stigmata of cor pulmonale in advanced disease. A sputum analysis may reinforce the diagnosis of bronchiectasis and add significant information regarding potential etiologies. The full blood count is often abnormal in patients with bronchiectasis. Typical findings are non-specific and include anemia, an elevated white blood cell count with an increased percentage of neutrophils. An increased percentage of eosinophils is one criterion for allergic bronchopulmonary aspergillosis. Alternatively, polycythemia secondary to chronic hypoxia may be observed in advanced cases. Chest X-rays are usually abnormal but are inadequate in the diagnosis or quantification of bronchiectasis. Tract opacities are seen in cylindrical bronchiectasis, and air fluid levels may be seen in cystic bronchiectasis. Overall, there is an increased bronchovascular markings, and bronchi seen on may appear as ring shadows. Pulmonary vasculature appears ill-defined, thought to represent peribronchovascular fibrosis. HRCT is a good tool at demonstrating the airways and is able to a greater or lesser degree to distinguish some of the various underlying causes. A number of features are helpful in diagnosing bronchiectasis. Bronchus visualized within 1 centimeter of pleural surface, most helpful sign for early cylindrical change. Increased bronchoarterial ratio, where the diameter of a bronchus is 1.5 times or more that of the adjacent pulmonary artery branch. Other signs on CT that describes bronchiectasis are Trem tract sign, signet ring sign, and string of pearl sign. After assessing for treatable causes, management is as follows. Physical training such as inspiratory muscle training, which has a good evidence base for patients with non-cystic fibrosis bronchiectasis. The specific term used is chest physical therapy and is generally performed by a respiratory therapist but can be done by a trained member of the family. Postural drainage of the sputum. Antibiotics, which are the mainstay of treatment of patients with bronchiectasis and infectious exacerbations. Oral antibiotics often are used to treat these infections. Bronchodilators, including beta-agonists and anticholinergics, may help some patients with bronchiectasis. This presumably reverses bronchospasm associated with airway hyperreactivity and improving mucociliary clearance. Immunizations. Surgery in selected cases, especially for localized disease, to remove segments of the lung or to control massive hemoptysis. Surgery is also done to remove an airway obstruction that is contributing to bronchiectasis. Single or double lung transplantation. Single or double lung transplantation has been used as the treatment of severe bronchiectasis predominantly when related to cystic fibrosis. In general, patients with cystic fibrosis and bronchiectasis should be considered for lung transplantation only when the FEV1 falls below 30% of the predicted value. Female patients and younger patients may need to be considered sooner. Complications of bronchiectasis. Localized complications include recurrent pneumonia, lung abscesses, and empyema. These are infections of the lungs, and due to the vicious cycle of impaired secretion clearance, these collections form a nidus for recurrent infections. Also look out for hemoptysis due to the endothelial injury caused by the distortion of the capillaries and smooth muscle layer within the bronchi. Patients also may develop cor pulmonale and eventually respiratory failure secondary to raised pulmonary arterial hypertension and failure in gaseous exchange respectively. Systemic complications include hypoproteinemia, amyloidosis, and septicemia. Now, let's summarize. Bronchiectasis is a disease which is characterized by permanent dilatation of bronchioles. This condition arises from infectious insults or obstruction to the airways leading to inflammation and impaired secretion from the airway. This then leads to recurrent infections and further distortion of the bronchial structure. Symptoms typically include chronic cough with mucus production, dyspnea, hemoptysis, and pleuritic chest pain. Clinical findings may reveal a clubbed patient with evidence of crackles that reduces after expectoration of sputum. Imaging and pulmonary function tests serve as important tools to diagnose and assess the severity of the disease. Management is focused at secretion clearance, pulmonary rehabilitation, and restoration of nutrition. We have come to the end of this module. Thank you.